Hello friends, I am Dr.Vasanthakumar Natesan. In this video, I am going to talk about septic shock, unraveling the mystery using Warburg common pathogenesis evolutionary model, which was proposed by myself around 10 years back. I had proposed Warburg common pathogenesis evolutionary model to explain various pathophysiologies including septic shock. I'll briefly discuss about this model before going to septic shock. To understand any disease or any pathology, we need to understand the evolution of eukaryotic cell. Eukaryotic cell evolved from archaea and rickettsia. Archaea and bacteria from rickettsia, and in archaea it's Asgard archaea, and they got into an endosymbiotic relation, and rickettsia started living inside the eukaryotic cell as mitochondria. Normally this is how it works. During pathologies, for example in sepsis, loss of endosymbiotic relation between these two genomes, that is mitochondria which evolved from rickettsia and nuclear genome which evolved from Asgard archaea. There is disruption in the endosymbiotic relation, which leads to overactivation of innate immune system and activation of aerobic glycolysis mechanism, which is called Warburg effect. For more details, please check my previous video. Many researchers have difficulty in understanding my theory. It uses concepts from different fields ranging from evolutionary biology, medicine, biochemistry, molecular biology, neuroscience, electrophysiology, immunology, etc. to systems level understanding. Being an expert in one field will not be helpful in fully understanding my theory. I am a universalist. So previously, in my last video, I had discussed Warburg common pathogenesis evolutionary model. So many might have thought it's just a theory. In this video, I am going to show how powerful it is, and it helps in solving the septic shock mystery. In this presentation, I will discuss only the vascular dysfunction in septic shock. For more details, please refer to my articles. I request the ICU specialists, intensivists, critical care specialists, and other doctors who treat septic shock patients to watch this video carefully, read my articles if possible, and share your comments. So these are some of my articles. Disclaimer: the discussions, concepts and hypotheses presented in this video are intended solely for research and educational purposes only. They should not be used for clinical purpose. So briefly I will discuss about the current understanding of septic shock. Warburg effect in septic shock. I'll discuss more about this later. And vascular dysfunction, how it happens. Don't think it's only due to nitric oxide induced vasorelaxation, even though that's the main trigger. And what is the danger in using norepinephrine? How it is related to bacterial quorum sensing? And do you see the paradox? Increased catecholamine level are seen in sepsis patients. If already catecholamines are increased endogenously, what is the point in giving catecholamines exogenously? Also, I'll discuss about how the adrenergic receptor changes occur in sepsis and what happens to vascular smooth muscle cell VSMC, and how the phenotype switch explains the dysfunction. Again, I request the ICU specialists, critical care specialists and other doctors who treat septic shock patients to watch this video and share your valuable comments. So, what is the definition of sepsis and septic shock? Sepsis is not just infection. It is the dysregulated host response to infection. And septic shock is defined as a subset of sepsis in which circulatory, cellular and metabolic abnormalities are associated with greater risk of mortality than sepsis alone. And how the septic shock patients can be identified? It's by the vasopressor requirement to maintain mean arterial pressure of 65 mm of mercury or greater than that, and serum lactate level greater than 2 millimole per liter in the absence of hypovolemia or irrespective of fluid correction. Septic shock carries mortality rates more than 40%. So what are the vasopressors used in septic shock? So norepinephrine is the main vasopressor used to revive septic shock, and other vasopressors like vasopressin, epinephrine are used. I will not discuss about the antimicrobial therapy and other things, so it will take a little longer. So I will discuss about the vasopressor problem. And treatment in most hospitals world over is based on Society of Critical Care Medicine Surviving Sepsis Campaign guidelines. As discussed earlier, sepsis is the harmful systemic response to the host to the infection. According to Thomas, the host response to pathogen is more detrimental than the pathogen itself. Septic shock is refractory to vasopressors in most of the cases. This includes norepinephrine, the primary drug used in reviving blood pressure in septic shock. Vascular hyporeactivity in septic shock is well known. Mitochondrial dysfunction, immune dysregulation also known very well. Irrespective of the advances in this field, exact underlying mechanism behind septic shock is still a mystery. I proposed Warburg common pathogenesis evolutionary model in 2016-17 to explain most of the pathophysiologies, including septic shock, as base model. So what is the current understanding of ICU or critical care doctors? Current understanding of septic shock by them. Most know dysregulated immune response, high nitric oxide, and how it causes vasodilation that leads to hypotension and tissue hypoxia and increase in lactate, and how high nitric oxide inhibits mitochondrial oxidase mechanism, and this leads to glycolysis and increased lactate level. Only few know that it is due to aerobic glycolysis, also known as Warburg effect, and no one knows I had already solved the problem. I was the first one to propose Warburg effect as underlying pathophysiological mechanism which explains everything in septic shock, especially vascular dysfunction. even though piecewise things are known, I was the first one to clearly show how this works. So, as told earlier, nitric oxide role, it's well known. There are two phases in the septic shock, early phase and late phase. Early phase is thought due to eNOS activity, and late phase is due to iNOS activity. And inhibition of mitochondrial respiration is very well known. Vascular smooth muscle cell phenotype changes also known in other pathologies, other vascular pathologies. So, it is very well known that catecholamines in the plasma were increased in sepsis. In spite of increased catecholamine level in sepsis, it seems odd to give exogenous catecholamines such as norepinephrine for the treatment of septic shock. Many had already pointed out it carries risk in treating septic shock. So, before going to explain further, have you ever wondered why adrenergic drugs produce different effects in different types of smooth muscles? That is, it produces bronchodilation. In bronchial smooth muscle, it produces dilation via beta 2 adrenergic receptor, and it produces vasoconstriction in vascular system via alpha 1 adrenergic receptor. You may think everybody knows it acts through different adrenergic receptors and produces different results. Remember this, I will come back to this later. Actually, this is one of the clue which helped me in solving septic shock problem. So, this diagram, during sepsis, increased catecholamines level through adrenergic receptor acts through PI3K AKT pathway and MAP kinase pathway, leads to eNOS hyperactivation, and later it leads to iNOS activation. And through cytokines and LPS triggered TLR pathway, it activates NFKB, nuclear factor kappa beta, through iNOS activation, it leads to high nitric oxide and inhibition of mitochondrial respiration by inhibition of cytochrome C oxidase, the fourth complex. Up to this part, most of the clinicians know, but it happens due to Warburg effect, due to metabolic phenotype change to glycolytic phenotype from oxpose, and cellular phenotype changes from differentiated to dedifferentiated phenotype. This Warburg effect part only very few know, and this is a local survival strategy for the cells, which finally results in the global failure of organ systems and organisms. And to understand this part, you need to understand the evolution very well, and please see my previous video for that. Why it helps in survival in the harmful environment. So, this figure explains what happens in septic shock in vascular system. Vascular smooth muscle cells are in differentiated state normally. Catecholamines in normal state through alpha 1 adrenergic receptor, which is a GPCR, G protein coupled receptor, through its G alpha subunit produces vasoconstriction through IP3 calcium pathway, DAG PKC pathway and rho kinase pathway. Normally, during hyperactivation, this pathway is inhibited, which produces decreased contraction or paradoxical vasorelaxation. Apart from this pathway, through G alpha, through G beta gamma subunits, through PI3K AKT pathway and MAP kinase pathway, leads to eNOS hyperactivation, which leads to high nitric oxide and reversible mitochondrial respiration inhibition. So, up to this part, it's reversible. So, Warburg effect happens, lactate started increasing in this phase, but this is the early phase of hypotension in septic shock. This can be reversed easily. And in the late phase of septic shock, the vascular smooth muscles changes a lot, not only through increased catecholamine level and adrenergic system hyperactivation, through lipopolysaccharide and cytokines, NFKB is activated, which leads to iNOS activation and very high nitric oxide level results, which leads to irreversible mitochondrial inhibition. This triggers the metabolic phenotype to change from OX to glycolysis, and cellular phenotype changes from differentiated state to de-differentiated states. And there are many subtypes may be there. Through vascular smooth muscle cell embryonic phenotype, the adrenergic receptor predominance may change from alpha 1 to beta 2. So what will happen? Adrenergic system, if it is activated through beta 2, it will produce paradoxical vasorelaxation, and later it will change to vascular smooth muscles change to proliferative phenotype, which acute effect results in decreased contractile apparatus and produces hyporeaction to vasopressors or paradoxical vasorelaxation. Chronic effect I will not discuss here. Vascular system during septic shock, it contains vascular endothelial cells, vascular smooth muscle cell and fibroblast. Vascular smooth muscle cell, its contractile time in the differentiated state. So all these things switches over to vascular smooth muscle cell synthetic or proliferative phenotype. That's the final endpoint. So norepinephrine in this situation may do more harm rather than reviving the hypotension. For example, if the receptor is changed to beta 2 predominance, then if you give catecholamines, it will produce vasorelaxation instead of vasocontraction. And if the vascular smooth muscle cell phenotype is changed, then due to decreased contractile apparatus, hyporeactivity or again paradoxical vasorelaxation may occur. It is interesting to see noradrenaline induced vasorelaxation in neonatal arteries in this context, where vascular smooth muscle cells are expected to be in embryonic de-differentiated state expressing beta 2 adrenergic receptor as the predominant one. Also, it has been shown already that norepinephrine induced vasodilation in the isolated coronary arterioles of heart failure patients. So here also the same thing. Vascular smooth muscle cells are in dedifferentiated state, and that may be the reason for this one. So coming back to this simple question, why adrenergic drugs produce different effects in different types of smooth muscles, especially bronchial smooth muscle and vascular smooth muscle. So it is well known that in normal conditions itself, catecholamines produce relaxation effects in intestinal and bronchial smooth muscle. Without knowing the significance, it is generally assumed that a simple model like catecholamines action via beta adrenergic receptor produced relaxation. I proposed that these bronchial or intestinal smooth muscle cells may already in mild Warburg effect even in normal physiological state. That's how they survive in these harsh environments. The normal physiological catecholamine response in intestine or bronchi, which produces relaxation, is equivalent to the pathological condition in septic shock, where catecholamines may produce hyporeaction or vasorelaxation. In other terms, vascular smooth muscle becomes like bronchial or intestinal smooth muscle during septic shock. So apart from all this thing, adrenergic system's role in bacterial quorum sensing also helps in understanding this. I had proposed in 2018 that adrenergic blockade inhibits bacterial quorum sensing and may reverse Warburg effect in septic shock. Mark Light pointed out that catecholamines lead to bacterial growth through quorum sensing, and this can be blocked by adrenergic blockers. Please understand, catecholamines lead to bacterial growth. In fact, bacteria use catecholamines system for their growth. Adrenergic system like primitive system for their own growth. Thus, adrenergic blockers not only decrease adrenergic overactivation and hypermetabolism, it may also inhibit bacterial quorum sensing signaling in septic shock. So, adrenergic blockers can be used as a treatment option for septic shock, which may work by blocking bacterial quorum sensing signaling in sepsis patients and thus decrease the innate immune system response and reverse the Warburg effect in septic shock. And the treatment options for septic shock, I had proposed many treatment options. For more details, please refer my articles. So what you have to understand is all the drugs used in septic shock should be used as differentiation therapy, aiming to inhibit or reverse Warburg effect and revive mitochondrial respiration, and thereby maintain the order of the cells, organ systems and organism in terms of differentiation. Norepinephrine may cause more harm than saving the patient. Alpha blockers in the early phase of septic shock, especially alpha 1, and beta blockers, especially beta 2 blockers in the late phase of septic shock, may be beneficial, and already many trials are already there. Many other possibilities are there, which I will not discuss in this video. So please remember this figure. So in this figure, how the vascular dysfunction occurs in septic shock is explained. Okay, so the model is not just theory, it can be used to solve key problems like septic shock. Thank you.